Hello and welcome to this diabetes skills video focusing on useful communication tools to enhance patient engagement. We do hope that you find it useful and enjoyable. Please share your thoughts in the comment section and make sure that you like and subscribe so that you don't miss any new content that we upload. Good afternoon, everyone. My name is Hope Frost, and on behalf of SPK Healthcare, I'm delighted to welcome you to this diabetes skills webinar. Today, we will be focusing on useful communication tools to enhance patient engagement. So it is now my pleasure to introduce your webinar chair, Su Down, who is Diabetes Nurse Consultant and Co-Vice Chair for the Primary Care Diabetes Society. Hi, Sue.
Hi Hope. Yes, and welcome everybody this afternoon. So I am going to be spending the next hour with you along with Cathe Gaskell, and I'd like to thank SB for asking me back to this next series of meetings. I did one of these with Cathe just before Christmas, and we had really good fun doing this sort of talk where Cathe will present and I will then come in and we will take you through the next hour. These work really, really well if you do ask us lots of questions. I can talk forever to fill that space, but it is really useful to link in with you to find out how things are from your point of view around the topic that we're discussing. So please do keep those questions coming in. I will be posing them to Cathe throughout her session and her take on the topic today that we have. And then we will have a bigger Q&A at the end, but keep those questions coming through. I will be monitoring those and answering as many as we can. Equally, yeah, if you want to put up in the chat what you are, what you do, your job role, then again, that's really, really useful for us to really feel that we're connecting with you throughout the session. So again, I'd like to call Cathe to turn on her camera. Cathe, like me, has been a nurse for many years. Cathe's background history is in mental health nursing, but more recently has been working a great deal in her company with change management, working across the health sector, getting us to improve and constantly improve with use of change management. The session this afternoon is going to be looking at communication tools. And my goodness, didn't we face a year last year, completely unprecedented times, suddenly having to completely change the way we all work, and that's not going away anytime soon. So I would really, really welcome Cathe here to start to open the session, and we will be batting to and fro throughout the next hour. So keep your questions coming. Cathe, over to you.
Okay, thanks very much. Hi, I'm just going to put my slides up. Here they are. Okay, so lovely to be here, and I can't thank everyone enough for coming on a Wednesday and sharing their time with us. So I really appreciate it. I hope you've got a cup of coffee, got your feet up, because I think it's going to be an exciting hour. Sue and I are presenting together, but we're also trialing a video. So fingers crossed that will work, Sue. I've got a bit of a surprise video in the middle, and I'm also hoping that it will generate more information and questions from you for the next couple of sessions we've got. So first of all, thanks everyone. Really appreciate you turning up today. So yes, the session, useful communication tools. And as Sue said, my background is mental health, but at the moment I'm working a lot in the region of conflict. So I'm going to be sharing some of the tools that I use in conflict and working with engaging with people who don't want to engage, because I've read that that's a real issue for you. You want some help with patients who don't want to engage, or patients who are resistant, or patients who are ambivalent. So hopefully I've got some tips that will be useful to share with you. Okay, so I was put my slides up from what we're going to be talking about today on the workshop. And we can't have a workshop about communication without talking about COVID, because it affects every area of our life. So we're just going to touch on the particular things that might impact on you building rapport and empathy with your patient. I want to talk about active listening. It's that old chestnut, and I think Sue and I might do a bit of a live play on, I'm gonna test how well we can listen, because my belief is that we find it really hard to listen in healthcare. I'm going to talk a little bit about Zoom and Teams and how they can impact on our relationship with patients, phone consultation as well, but I want to end on motivational interview skills. Just a brief introduction, because I know some of you will be experts in that. It's already used a lot in the world of diabetes, but I want to share some of the insights I have because I use it in conflict. So I'm hoping that I can share some of the insights of how I encourage staff to talk using these motivational interview skills, and they particularly work if people are ambivalent. So hopefully that'll be useful. So again, COVID. I was looking at some research on communication because we're really just starting to realize the impact that COVID has on our patient relationships and building rapport. And the University of Essex is just starting a piece of research because they already identify it's reshaping our speech communication. We know that we are sometimes face-to-face wearing coverings that affects both parties, it distorts speech, but also teleconferencing is, it's difficult. And as I said, when I did a session on teleconferencing, do you know what? A lot of our patients don't like it. So I really want to talk about how we can use that, because there is a pause. You at times can't get the transmission, but it is still the best opportunity to build rapport if you can't see people face to face. Because teleconferencing, like we are now, is still the best option in terms of reading patient behaviour. So I'm going to talk a bit about that. Wellbeing and stress. Well, isn't wellbeing the hot word at the moment? So I took this off a website looking at the effects on stress and us and stress affecting patients. And it's just something I want to remind us. Sometimes when we go in to see a patient, and sometimes when I'm talking to staff, I wonder why there's resistance. And really, it's important to keep at the forefront of my mind what people are going through. So we know people are worried about their own health, yes, loved ones, financial situation, all of those things could be playing into the context when we see someone, but also difficulty sleeping or concentrating. Now, I've read that 60% of people are having difficulty concentrating around COVID. I think it's higher than that. So we certainly know people who've had COVID, they're impacted cognitively, but also because we have this free-floating anxiety, most of us are finding it difficult to concentrate. And certainly I'm giving a lot of advice to staff on not multitasking. So doing one thing at a time, not being able to set yourself a whole day of Zoom like we used to. We really have to adjust our expectations of what we can do. So concentration is really impacted. And again, this is really important because if you're trying to build rapport with a new patient or you're working with a resistive patient, and for me, I'm working with resistive staff, these are things that I have to have in the back of my mind. And the other thing there, we do know that there is an increase in alcohol use for a number of people, self-medicating through anxiety. So when I see someone now, when I talk to staff, I'm really now holding in my brain that this person is also coping with all these different issues. And that may be why I'm having resistance to building rapport or having a conversation, or if I'm wanting them to deal with issues, conflict issues. Okay. So put this one up there for you. You are working through a pandemic. You are working through a pandemic and a historical revolution. So Black Lives Matter and the demise of Mr. Trump has had an effect on people. It's had a political effect, it's in our psyche, but working through a pandemic is a pretty amazing thing to do. But don't beat yourself up if your mental health isn't the best right now. And I say that to everyone. We're on third lockdown, we're tired, we're exhausted. So you've got to bear that in mind as well. You've got to cut yourself some slack. Now, we're not very good at this. We are not very good at well-being in healthcare. We're really good at looking after patients' well-being. So I'm just putting a little caveat in here. Remember the work you're doing when you're finding resistance or you're worried about your patients or you're looking at communication. We're in very unique times. So yes, don't take it for granted that working through a pandemic isn't a pretty exceptional thing to be doing. Okay, so going on to my old chestnut of active listening. So why this is so important is because it's something that we're not taught. So my background is nursing. I was never taught active listening, and working in conflict and working in mediation, it's been a skill I've had to learn. And because I'm a curious person, I tend to ask questions. And actually active listening, there is a place for questions, but there is a place for silence. And for people like me, that's really hard. So this is something I've really had to learn. It's a challenge to build rapport. But I'm going to talk to you about how questions can actually be diversionary. But active listening is a skill that we need. And it's often patients need a good listening to rather than a good talking to. And where I use this is if I'm dealing with complaints or if I'm dealing with really deep-seated issues, I bring active listening skills. And active listening is just that. I am listening intently. And I'll talk to you a bit about that. So one of the things with active listening is the importance of eye contact. And sometimes we lose that because we are taking notes. And of course, I do understand that you're taking notes if you're having a virtual consultation or phone consultation. But if you're having a virtual conversation, there is something really important about eye contact and the way that patients read our body language. So one of the things that we talk about is no distractions. And it's so easy to multitask, to perhaps check your phone, to do other things. If you are building rapport, you've got to focus on one thing. And it's so important. If you want to get rapport and empathy with a patient, you want to build the trust and the relationship so that they will confide in you, divulge more, you'll work together, you work alongside the patient. Eye contact, no distractions, no interruptions. I know at times we've got to take calls, but we know that patients tell us that that break in the conversation can be really difficult to pick up. And this is the one, no questions. Now, you're going to say, how can we have a clinical assessment without questions? So one of the things that psychologists recommend is you have a download time. So when someone is speaking and you first go and see them, or you ask them how their week's been, because we're going to use open questions. That open question, tell me how your week's been, it's really easy to pepper it with more questions. Actually, to give people about a minute to 2 minutes, it's a very short period of time to download and tell you, is a super skill in active listening. So my temptation will be to jump in and to say, what did you mean and how did that go? Actually, 1 minute of solid listening, because that's a period of download. I'm actually telling you the stuff that's bothering me. I'm worried about it. I'm telling you, is great if you can just hear it. And that's really difficult. So Sue, do you want to do a live? Should we do a live practice on that?
Oh goodness, yes. Let's try. I was laughing as you said that because I am hopeless. I always want to ask more questions, and I know even if I'm having a discussion with professionals, I do exactly the same. So yeah, this is going to be a challenge for me. Okay.
So I thought I'd get you to ask me how my week's been, and I would just download, and I'm going to put a timer on. And the torture is you can't say anything. So I want you to show me you're interested by nodding or smiling, but you can't speak. And I just want to see how it feels, because I think our natural temptation will be to come in with a solution.
Okay.
Okay.
Here we go then, Cathe.
Yeah, I'm going to I've just got my phone here. You just put my timer on. I'm going to start now. So you're going to ask me, how's your week been, Cathe?
So hi, Cathe, how are you today? And just tell me how your week has been.
Oh, so I'm on the Corona coaster. I'm up and down mood-wise. So the thing that's really upsetting me this week is I'm a new grandma, and I've only seen my grandson 3 times. And I'm having all sorts of crazy thoughts about breaking lockdown and sneaking off to see him, because he's 6 months old and I've only been able to see him 3 times. So I have been shielding, and also so I know I'm clinically compromised, I have asthma, but it's really getting me down. And I just feel that it's unfair. I don't know why this happened to me. Why have I developed asthma? why has it meant that I've had to be locked down? And well, everyone's locked down, but I'm shielding, which is a real pain. And I just feel this is never going to come to an end. So I'm feeling really distracted, and I'm not sleeping. And when I don't sleep, I don't always take my asthma medication, so I'm not always medication compliant. And I think it's about resentment. I'm really resenting. I'm a nurse. I've been healthy. How have I ended up with this illness, this disease? And I have to take steroids. And why do I have to do this? It seems so unfair. But it's really making me want to think about, breaching rules, and other people go out and people see family at Christmas and I didn't do that. And, I'm just wondering where this is all going. So I'm just feeling really down at the moment, and feeling like I'm left out of the family because I can't go and see people. And it just makes me feel really, really sad. And I feel really frustrated about not seeing my grandson. And, he's going to grow up and he's not going to know he's got a nana. And, he could be 2 by the time I see him next. It's just going to be crazy. And I just really don't know what to say. So that was 2 minutes.
Okay.
How did you find it?
There were a lot of times I wanted to empathize with you and sort of say, that there's a lot of people in the same boat. That's an obvious thing that I wanted to say. Again, when you were talking, there were different things, when you were talking about wanting to break the rules, it was like, okay, let's, and then the other side, the fact that it was really starting to affect your mental health, and then medication compliance and stuff there you wanted to pick up on, but you really sort of felt for you. So I wanted all the time to come in and say supporting words, if nothing else, is what I wanted to do.
Yeah, I think that's natural. And I think sometimes people just like to give off. So I know I can't break lockdown rules. I know that's a silly thing to say, and patients know at times I say silly things, and some of that you've got to ignore. I go for, that sounds really difficult.
Yeah.
Because I know I'm talking nonsense, and sometimes we just say that stuff, and it's hard sometimes as a clinician not to pick up on the details, because we hear breaking lockdown, that's bad, not taking medication. Sometimes in that 2 minutes I need to download everything. What I advise we do after that 2 minutes is summarize what was said. And when you summarize it, sometimes as the adult will come out of me, because I've just basically had a moan. And it's great you didn't interrupt me. I had a moan. But if you summarize it, so this is really important to you, Cathe, this is what I think you said. You're building rapport with me because I think you heard me. But it's so tempting to go in there, and it's really good that you withheld judgment, because I was putting some triggers in there to get a reaction. It's really good you withheld judgment, because patients do that. They tell us stuff that makes us go into parental mode and say that's not right. And we're going to talk a bit about that. It's really hard to hold on to judgment and just think they're getting it off their chest. When I summarize, let's see if that's actually important for them. So thank you for that live presentation and putting you on the spot there. So just going back to, this one, tone. The impact of tone on email and in person. So I thought, Sue, you gave me a really nice piece of feedback. So often, so I'm talking about myself, so often if I get frustrated, so I'm trying to work with staff, I want them to deal with this conflict that's making them so unhappy or so unwell, and they don't, I have to watch my tone, because it's so simple to come across as being critical. And the other thing is, we can have tone on email. So I've had a couple of people write to me this week and say, I'm really offended that someone wrote to me, I didn't like their tone. So be aware, tone can come across in email. We can be incredibly direct in email. So just to reiterate, within relationship building, email is 4th on the list. I'm trying to build a relationship. Well, really, it's 5th. One-to-one, we can't do that in lockdown necessarily. The next one is face-to-face, like this, remotely. Then it is phone, then it is messaging, and 5, it is email. And the reason email is great, email's really great for disseminating information. It's terrible for building relationships because I can't read the tone, I don't see the humor. And it's one of those things we have to be really careful with patients, particularly around delivering any difficult news. Do not do it on email. It goes so badly wrong because the email can be read in different ways. So I would say email for disseminating information, or email for following up on a conversation. We had the conversation and this is what I think we've agreed. Or safety netting, that's great for email. But actually, any discussion really about health, email is disastrous because I can read it a different way than it was meant. So watch tone on email in a person. So again, this is all about rapport. How do I build that patient rapport, the patient who is really struggling with their diagnosis? Listen to understand. And that's one where I put judgment comes in. Sometimes when people are telling us stuff that we don't agree with, the nurse in me wants to tell them immediately what they've got wrong. Really, everything we've learned about rapport is that if we shame someone, even unintentionally, we don't mean to shame our patients, but comments we say, even unintentionally, can affect that rapport and that ability for them to tell us. So for me to say, I'm not following my medication, Sue, I'm not looking after my asthma, listen to understand. And I think what was really good was you heard the distress in that and the mental health issues in that. So listen to understand. Now, Hope, this is where we're going to try and put a little video on, because I've got a little video that I think illustrates listening to understand really well. It's one by Brené Brown that many of you will have heard of. So she's a researcher and she's also a psychologist.
So what is empathy and why is it very different than sympathy? Empathy fuels connection. Sympathy drives disconnection. Empathy, it's very interesting. Teresa Wiseman is a nursing scholar who studied professions, very diverse professions where empathy is relevant, and came up with 4 qualities of empathy. Perspective taking, the ability to take the perspective of another person or recognize their perspective as their truth. Staying out of judgment, not easy when you enjoy it as much as most of us do. Recognizing emotion in other people and then communicating that. Empathy is feeling with people. And to me, I always think of empathy as this kind of sacred space when someone's kind of in a deep hole and they shout out from the bottom and they say, I'm stuck, it's dark, I'm overwhelmed. And then we look and we say, hey, you can climb down. I know what it's like down here, and you're not alone. Sympathy is, ooh, it's bad, no, you want a sandwich? Empathy is a choice, and it's a vulnerable choice, because in order to connect with you, I have to connect with something in myself that knows that feeling. Rarely, if ever, does an empathic response begin with at least. Yeah. And we do it all the time, because you know what? Someone just shared something with us that's incredibly painful, and we're trying to silver lining it. I don't think that's a verb, but I'm using it as one. We're trying to put the silver lining around it. So I had a miscarriage. Oh, at least you know you can get pregnant. I think my marriage is falling apart. At least you have a marriage. John's getting kicked out of school. At least Sarah is an A student. But one of the things we do sometimes in the face of very difficult conversations is we try to make things better. If I share something with you that's very difficult, I'd rather you say, I don't even know what to say right now, I'm just so glad you told me. Because the truth is, rarely can a response make something better. What makes something better is connection.
Great. So I refer to Brené Brown all the time because some of the stuff that she says is just so powerful, and it is about connection. Now, I'm certainly not saying, Sue, that you're going to be hugging your patients. That's not what I'm advocating, but I am about that listening for the feeling and the emotion in some of the stuff that people are saying. Yeah, this is one I sometimes say, mind your language. When I'm trying to build rapport with people, I have to watch my confirmation bias. And confirmation bias is when I assume something about you, so I sort of want to prove it. And I'll give you an example in a bit. But confirmation bias is, you would say at the moment that Donald Trump has confirmation bias. He believes that he won the election, so he's looking for all sorts of evidence to prove it. That's sort of overt confirmation bias. and then watch for the silver lining. And that's something that I'm finding people are doing a lot in COVID, and we mean it to be helpful. But I'll hear someone saying, oh, I'm feeling really scared at the moment. I'm really worried about my health. And someone will say, well, I don't know what you're worried about. At least you've got a job. That is a silver lining, but it doesn't make the person feel better. And so just a little thing, and I've got a couple of examples here. So confirmation bias that you might have from a patient. I'm worried about weight fluctuating. Sometimes we say stuff like this: you have a tendency to put on weight, are you still consuming a lot of high sugar drinks? Yeah, you wouldn't want to be saying that, because that confirmation bias is just under, I guess it's just saying, this is what I think about this person, this is, I know that they don't stick to the diet, these are the sort of things they do. And the silver lining, now this is one that I do know, because I've had members of the family have it said to them, worried about a potential miscarriage with my diabetes, you're young enough to try again for a baby. That silver lining doesn't help. It might make the person feel better saying it, but actually we're slipping into shame, and the person thinks, oh, I feel stupid for bringing that up. I wish I hadn't said that. So just language is so important. It's so important. Bias and silver lining. Okay, so moving on to phone consultation tips. Some of you will be doing phone consults if you go, and I just wanted to bring up some of the sort of top things that I've covered before that I think is so helpful. So is it the right person? Now that's a really strong assumption to make, yet we are hearing that people are passing the phone over to other relatives, they are letting other people call in. So just check, is it the right person? Can they speak? And it's so important to establish the purpose of the call early on, because people don't know why you're calling. It may be a book call, but it's so important. I know when I get calls from the doctor, establishing the purpose of the call, what are you calling about, is really important. Now, confirmation of the patient's past history. The reason I put that in is because I look at trends around serious incidents, and some of the serious incidents, particularly relating to telephone consultations, around an incorrect past history being recorded. So it's always useful just to confirm that you've got the right information in terms of helping with your diagnosis and your treatment plan. Start with an open question. That's really important, about the week or your current condition. But this is another one that is really helpful, and I see it again in serious incidents, that people weren't asked about specific signs of deterioration. So it's just actually making sure that gets in, because sometimes patients won't tell us, or sometimes they're anxious, particularly phone consultation, particularly with older people. So asking a specific sign of deterioration questions can be really helpful. And then I put safety netting in, because again, I think I was saying to Sue, in serious incidents, only about 40% of the patients have had a safety netting conversation. So when they review the case, it wasn't recorded. The safety netting advice is, what do you do? Signs get worse, and where do you go? What do you do in the event? So safety netting is for us as well as the patient's protection. It's really important. But if it's only found in 40% of serious incidents, it means that there's a gap. Now, I know that some of you will write to the patient and give them that safety netting advice, but it's so important to get it in the notes. I don't know if you want to chime in here, Sue. What are your thoughts on that?
It's really interesting, because we've already had a comment come in when you mentioned safety netting earlier. It was, what is safety netting? And I think this is absolutely key here, because again, whilst we are working predominantly remotely, and even there's so much evidence about this face-to-face, what we may say in a consultation is not always what's heard. And a lot of the time we don't double check that somebody has heard what we feel we have got across. So to me, safety netting and saying, should this happen, we're all out here now trying some pretty intensive therapy changes, regime changes on people completely remotely, insulin starts, injectable starts, blood glucose monitoring. And it's absolutely key that somebody knows exactly what to do if and when, because this is a very strange situation. So yeah, totally agree. Safety netting has to happen.
It's sort of a new COVID word. We've got all sorts of words, but yeah, it's a new COVID word. Safety netting is so important, and it's got to be written down. But I also like what you said about getting people to repeat back that they've understood the message. Now, some people think, is that patronizing? It's actually a safety check, because we also know that people may be cognitively impaired. So it's just so important to check back what patients think you've said to them.
I also think it's down to language, isn't it? And we are very jargonistic in this, even without thinking about it. We're quite full of jargon. So what somebody interprets from what we say. So I always get them at the end to just run through what they thought we talked about or what they might take away, just to see what it is that they've said. And it's so interesting to see what they pick up from a consultation that was not anything that I saw as being important, and to them was quite majorly important, because that's what they remembered.
Yep. No, really helpful. The next one is Zoom tips. So I think I've touched on this. A lot of people are not comfortable on camera. So I think when I looked at the increase of phone consultations, it's doubled. It's huge. Actually, Zoom or Teams consultation, it's only gone up by 1 or 2%. Patients still feel quite uncomfortable. Also, there can be some issues around, again, any cognitive impairment, or people as they're older, can they use it? Do they have a laptop? But it can be really useful. So you do need to have a well-lit room. And I've got 2 lights on. You've got to move distractions. And one of the tips is patient notes. There have been complaints that patient notes have been visible on a Zoom call, other patients' names or notes behind. So it's really important to think about that. Show your hands and arms. So you see me, I'm moving a lot. Patients report they like to see that. They don't just want to see the top of our heads, which happens if you're writing notes. So arms and hands, some reason, make people feel safer or make them feel that you're relatable. And then also, you're also taking note of the non-verbal clues. So particularly relevant for your patient group, their breathing, the colour, signs of pain or discomfort, how they're moving. It is great if you can get people on camera. It's a more accurate diagnostic tool in terms of serious incidents than phone. Because on the phone, the patient may not report that they are in pain, but actually you can see it. So in terms of if you're not sure about somebody, this sort of a call is a far more accurate tool. Even though there might be some drag in the delay of what we're saying, visually, you get more of a picture of the patient. Okay, so now I'm going to take us on to what I hope will be some of the actual tips I can give you that I use. So motivational interviewing, it's been around for a number of years. It came around from counselling, and it is used quite a lot in the world of diabetes. So one of the reasons I like it is because it helps patients and staff when we're ambivalent. So it's fairly normal to be ambivalent about change. That's a good thing. Ambivalence means you're moving from saying no. So although we struggle at times with patients being ambivalent about their care, at least they're not saying no. So grab that ambivalence and use it. Now, my background in using motivational interviewing is to encourage people to look at conflict and move forward. And I'm hoping that will tie into what you might use it for. So we know that evidence tells us, and I've got a research paper included in the pack at the end, that you want to prevent complications of diabetes, and that's a lot about self-management, self-care, and those are the sort of big topics you want your patients to be taking responsibility for: exercise, diet, medication adherence, routine follow-ups, and other things. These are the constraints that are reported. So these are what people are reporting stop them following up these behavioural changes. And I put at the bottom lockdown, because I know I can't get out and exercise. I know I can't get out the gym. And I tell you what, it's a rainy day like today, I'm very unlikely to be getting my 5,000 steps up, because lockdown does give us that excuse to be inside and doing less self-care. So looking at the evidence, that's what we want people to do. These are the constraints that people are saying. And again, financial costs, going to the gym can cost people, transport issues, access to healthcare. So what I want us to do is think about more of a coaching style, which is how I'm using motivational interviewing, more of a coaching style. And I just wanted to have a look again at research about what are the traditional behavior techniques used to get patients to change behavior. And yeah, they're written out pretty bold. scare tactics. We tell people, you know, in nursing, you're going to have a heart attack, or you're at risk, or advice giving. You have to be in the receptive mode to want advice giving. Badgering, that's actually a research term. We badger patients. And also more directive styles. So these traditional behaviour techniques, usually ascribed to nurses, have been listed as not being helpful. Patients will listen, feel ashamed, feel disconnected, and present as resistive and not want to change. So just to be aware, this is what we have done and what are we moving to. So motivational interviews. We're not going to cover it in a huge amount of detail because I think we might save that for a whole session, but just to get you to really think about what you could do with a patient that's you're finding difficult to connect with. So open-ended questions, which we talked about, and I've got a list of them to give you some ideas. Making affirmations, and affirmations really in this instance are more about recognizing when something positive's happened. Now, you do that anyway, but evidence is that patients really value when they've had a goal and they've met half of it. So I haven't lost any weight this week, but I have managed to do my exercise, affirmations. And it's described as coming alongside the patient. That's what literature describes it as. You're in a journey with the patient, you're alongside the patient, and you accept there's ambivalence. But you're alongside the patient, and you encourage and you make affirmations using reflections and using summarizing. And also the big thing in motivational interviews is goal setting. So I do this when I'm trying to work with someone who's ambivalent. I want to get questions going about what is it that's important to them. So I put some questions and affirmations in here, and you may already be using these, you may be familiar with them, but I use these a lot. Particularly things like, how would you like things to be different?
I use that a lot.
What do you want to do next? So I use these open questions. What would you most likely do? And the ones I use are, what would a good day look like? Describe a good day. Really get them to tell me what a good day would look like. Help me understand. So the open questions are really important for goal setting, particularly if you're going to set some small goals with someone who's stuck. You use the open questions to draw out that information, but also the affirmations. And I'm going to give you a little linguistic tip. It's one that makes it hard to say no. So this is a linguistic tip. If I want someone to work with me on something, I will sometimes use the phrase, so you look like the sort of person who would go along with this. You seem such a reasonable person. It's very hard for you to go, no, Cathe, I'm not. I'm unreasonable and I won't go along with it. So it is quite a good linguistic tip. So if I'm wanting someone to try something different and I've explained it, and I say to them, will you try mediation? Mediators often say you'll follow it up with, so you look like the sort of person who would use mediation. Is that right? I haven't had a no yet. So it is trying to get someone to buy into trying something. So open questions, affirmations, goal setting, which is SMART goals. And then also at the end, coming back. Now, one of the things that people said they really liked was they liked a coaching approach to behavior change. So I looked at the piece of research and people were saying, it's really easy to feel told off, to feel ashamed, to feel, embarrassed, to feel I haven't done the right thing. Lifestyle change is hard. It's really hard to start doing new behaviors and habits, partly because I'm fueled by anger, because this is unfair and unjust, partly because I'm frightened. But actually that coaching approach, and what people said was they really liked it when the person they're working with came alongside them and talked to them and said, okay, that didn't work this week. What are we going to try that next? And that positive approach, they were waiting for the shoe to fall. They were waiting for Sue to go, that's really disappointing. When it didn't happen, you got buy-in. You really got buy-in, because everybody likes to think I'm trying, I'm doing something. So this is just a quick run through, but I use it a lot when I'm trying to get people to try new habits. Now, another thing I say, I don't say it very often, but if somebody seems really stuck, and they're doing something that's quite destructive, I'll say to them, what benefit are you getting from this? I say, I've got no benefit, Cathe. I'm crying all day. I hate the person I come to see at work. I can't try mediation, but I'm so upset. And I say, okay, but what benefit are you getting from this? Because sometimes you just want to shift that victim, I'm stuck, I can't move. And that reflection on what benefit I'm getting, people think, well, actually, I'm not getting any benefit from being sad, upset, hating the person I work with. Okay, why don't we try mediation? So sometimes I use that to help unlock why I can't try this. And why I can't try this is I'm scared. I get that. And your patients will be scared and resistive, and lifestyle change is hard. So just start thinking about some of these things as useful, as tools, as something you can try. And then we're just going to move on to the goal setting, which I think at the NHS, we're all pretty good on this, the SMART goal setting, but using it with patients can be a different tool of helping them identify the goals and then using goal setting to work with them on it. Because it's tangible. I know there's nothing worse than going to the doctor and being asked, you taking your asthma medication? Are you keeping up to date? I'm just going to either say yes to get them off my back, or I'm going to change the subject. I don't want to talk about it. Actually, goal setting is a really helpful way to get me to focus on the stuff I am doing. So just to think again, why motivational interviewing works, it's because it's about the language of change. So you're coming alongside the patient, positive affirmations, and the language of change, and you'll get buy-in and you'll get movement. Okay. So I put some.
Oh, we seem to have lost Cath's connection there for a moment. So whilst we are waiting for Cathe to come back on board, obviously you can see the additional reading there. A couple of comments have come in that everybody can see in the chat box. Please do send in any questions that you have from this. But a couple of the comments are, one, I find it hard to know when to chip in sensitively when somebody's a lot to offload. How do you sensitively move them onto their diabetes? And the other one, which I think really ties in, I'm worried I'm going to forget what I've been told, waiting for patients to finish talking. And therefore, I'm guessing the temptation is either to pull them up or stop them or write things down. So certainly from my experience, when we listen to what Cathe has said, a lot around the listening, the active listening, and for me, the history taking, if we're trying to find out why somebody's sat in a situation where their diabetes isn't moving on, or, they're not really connecting, actually, if you find that when they are offloading, it is about everything else to do with their diabetes, to me that speaks volumes. We're not going to be able to move the diabetes on whilst everything else in their life is so important. And I guess unless we really acknowledge that and appreciate where they're coming from, we're never going to change anything in the diabetes. And I'm guessing the real challenge for services is that we have so many competing problems. When we have a consultation, it may be to do a review. We've got so many things we've got to get through, that actually the person is really challenged. Oh, hi Cathe. I'm just answering a couple of comments that have come in. So to me, allowing somebody that time to offload, if none of that offload is related to their diabetes, that speaks volumes.
Yeah.
And equally worrying about forgetting what they've said whilst, by the time they finish speaking, I'm guessing as well, that means if we're really tuned in and listening to what they say, you won't forget it. Yep. Because you are on that journey with them. I guess, sadly, what a lot of us do is we ask that question, tell me about your week. We have already switched off whilst we're counting down a minute so that we can get on with other things. But to me, if we are really actively listening, the clues are all in that chat as to what you need to do next. And it may not be diabetes as the first target.
Yeah.
Sorry, Cathe.
No, you're right. During COVID, it could be mental health. It could be well-being, because if our well-being's not right, if our concentration's not right, if my sleep's not right, my health's going to deteriorate in other ways. So you're so right. You're listening for the key things that person says. And when you paraphrase and you go back, did I understand you right? Tentative language. Did I get this right? They'll sometimes say, no, it wasn't that. That's not bothering me. It's not so much my weight. I'm really, really worried about this. So and
I'm guessing going forward, and again, please do either put in the chat box or in the Q&A box, because I think what you've been through, Cathe, and focusing it, I mean, I love the fact that you focus it from a different angle, and from that conflict, because when we are trying to engage with patients, this really is the challenge. But all of this that we've talked about can be dealing with colleagues, can be dealing with patients, can be dealing with anything, and it is really, really challenging. I was part of a piece of global research looking at patients who engage really early on with their diabetes and those who don't, and it came down to this was it was a questionnaire. We questioned healthcare professionals and patients from all over the world. There was 27 countries involved to get really different perspectives. And the patients who engaged best and quickest and felt they owned their diabetes were those where that conversation was right at the start, and that conversation, when they broke that down, it was if they felt that the person giving them their diagnosis or having that conversation had empathy. So when you were talking about empathy right from the start, I was like, oh my God, I was part of this global research that said the more empathetic the healthcare provider, then the greater the person will engage with their condition, whatever condition that is. So it's, and then your video backed that up fantastically about what's empathy and what's sympathy. So yeah, it's all about language and how we have these conversations. So, and I'm also really hoping the comment that came in about safety netting, that we really sort of back that up and finish that off. So no other questions have come through yet. I'm just wondering, Cathe, because I know you suddenly sort of left us once you put up your additional resources. Is there anything you wanted to say in summary? Because we've still got about 12 minutes to go, depending on how.
So I just put up the resources and really was just opening up for questions. It's been a real whistle-stop tour because I'm trying to give you lots of little tools. So active listening, which I say is a skill we've got to practice, but also thinking about language, because sometimes we make those slight asides and that confirmation bias. I know that my husband often, when he goes to the doctor, he takes great offence when she says things like, oh, have you been eating pies again? Now, he's from the Northeast. He doesn't eat pies. There's an assumption from his accent that he eats pies. And he gets so frustrated when, so that's confirmation bias. Oh, you're from the Northeast. You must be eating pies and fish and chips. He's like, I'm not. Cathe makes me eat organic. But that assumption, so he gets very anxious, he doesn't want to go, he gets quite resistive, and sometimes, see, that might be banter, that might be somebody trying
trying to be funny,
but actually he's really taken offense. So it's little phrases about language. Be careful about confirmation bias, and also that silver lining. I do hear us do that a lot in COVID with people saying, I'm really worried about this, or I'm worried about coming back to work. But so you've been shielding for months. What have you got to worry about? Actually makes the person feel so ashamed. Our shielding staff are having a real difficulty integrating because of anxiety. And you just got to watch language around that. And again, our colleague moods can really affect our relationship and rapport when we're dealing with patients.
So somebody's put in the comment box that they are guilty of silver lining things. Silver lining-itis, she calls it.
Oh,
Martha, I'm sure we can. So I think, I mean, language to me, I've always been, I've spoken loads about the fact how jargonistic we are, the things that we say and how people interpret what we say. And it's like, oh, I mean, the weirdest and most off the wall ones. I had a young girl, we were on a Daphne course, so she had type 1 diabetes, and I was talking about injection technique and sites, and I said, where was she injecting? And she said, here. It's like, shoulder, there is not a book in the world, there's not a leaflet in the world that would promote injecting in the shoulder. And she said that as a child, she remembers being told to move her injections around her body. So she did literally up one leg, up her body, round and down. And every time she went to an appointment, she was asked, do you move your injection sites? Yeah, I do. So she took what she thought she'd heard, she followed it, and she answered her questions correctly.
Yeah.
Nobody from our side had ever checked, had ever looked, had ever questioned and explored her understanding of a throwaway comment that was said. Yeah. And you hear this all the time, don't you? When in terms of, we think in a consultation, we have said this. We also know the evidence that people will pick up about 20% of what is said. We need to make sure it's the important 20% that they take away. And that's why I quite often double check at the end, because what they come back with first will be the main thing that they remember. And if that is nothing related to what I thought I'd said, then there's a real problem.
So we know patients remember better if they're asked to do something. So if you tell someone, you can, if you show someone, but actually if they're asked to do something, there's some interact. That's why we'll get better buy-in with goal setting, because it's my goals and I get to say when and how I do it. You're far more likely to get buy-in than telling someone you've got to change your diet. What does that mean? What does that mean you've got to change your diet? Actually, goal setting about, I want to lose half a pound a month, or I want to reduce my takeaways. All these little things are things that you can measure and actually say, yeah, I've gone down. In 2 weeks, I'm only going to have a takeaway on a Friday night. Okay, that's a tick. That's a tick. Yeah. Then move it on. I'm going to treat myself to takeaway once a month. Great. If you're trying to lose weight, that's a brilliant thing to do. It's those little things that goal setting. And also I love the thought of getting alongside the patient and saying, we're in partnership on this journey. We're going to help you. Together, we're going to work on this. And that takes it from being authoritarian and telling to working with. And I love that model. Alongside, motivational interviewing is alongside. So those are some of the things that I think, particularly when we've got the additional stress of COVID, we need to look at how we're working with people, because people are scared already.
They are. And one of the things that I do, if I do get video consultation, so the one clinic of mine where people really take up video consult well is in the antenatal clinic, and whether that's just the cohort, the age, that they're not bothered by video consult, and so we do a lot of that. Others it's more challenging, but what I found is when we were talking about the consultation targets, whatever we were working on, I would get them to write it down. I could see them write it down, because in the antenatal clinic, I then write in their record book. But of course, if I can't see them, I couldn't write in it. And to me, that's the legal document in the future. So we devised a way of saying, you write down what we have discussed today and date it. Now, for me, that was covering us legally. Yeah. But actually, I found they followed it. They actually put in place what we said far more effectively because they had done the writing.
Yeah. So Jen Menton said something. I believe we try to fix people when it's always better if they can find their own solution to the reason. And that's the evidence coming out for every aspect of well-being at the moment. We can drop solutions in, but if I'm not listening, if I don't feel you've got me, I'm not going to do it. If it's my idea to lose weight, if it's my idea to exercise, I'm much more likely to do it. That's an evidence-based piece of research. Patients who decide themselves, have some choice, have some autonomy, will do it.
We can also look back there beautifully to some of our medication classes. So GLP-1s are an injectable at the first. We also, people wouldn't go on to insulin because everybody was needle phobic. Nobody wanted insulin. Actually, that's right. There is a stigma about insulin that patients hold. When GLP-1s first came out, actually, they were very challenging to take. They were very challenging to mix up. They made you feel sick. You had to take them an hour. The first ones you had to take an hour before food, 6 hours apart. And the side effects were atrocious. And we were all saying, people won't want that. I had patients queuing around the block because they wanted it. They wanted it because they believed it would help them lose weight, which it did. But they would then deal with the side effects. They would deal with taking it. Now we've moved on, and that treatment, that class of medication is standard in diabetes practice. We are the ones saying, I think you now need, and people won't take it, don't want to take an injectable, don't want to feel sick. They are not part of the decision making in the way that they were when this class first came out, and unless they buy into it, they won't take it. Yeah. So yeah, I see that all the time, and we do try and fix people. So yeah, totally agree with those comments. So Cathe, we are very near our time. We have had an amazing amount of people listening in. So this is being recorded. You can all see this again. And thank you so much for joining us. We are repeating this again, or there is another one in the series next week and the week after. So do come back and join us again. Cathe, I just want to thank you. I love working with you and talking with you, and springing that live demonstration on me, which I wasn't expecting. So thanks for that too. And back to Hope.
Thanks, Sue. Bye, everyone.
Thank you so much, Sue and Cathe. That has been brilliant. And I'd also like to say thank you to Abbott for sponsoring this webinar. Thank you very much.
Thank you.
See you. Bye.
Bye.